Welcome to AETCM, the Emergency Medicine channel. Today we will be discussing about a dermatological emergency. A 18-year-old female was brought to ER with complaints of multiple skin and mucosal lesions since the last 4 days. Initial 10-second assessment, patient was conscious, oriented and obeying commands. Primary survey, her airway was patent, there was no gurgling, pooling of secretions, hoarseness, but there was erythematous and crusty lesions over the lips, restricting her mouth opening. Breathing, her respiratory rate was 20 per minute and saturation was 99% in room air. Air entry was bilaterally equal and there was no added sounds. Circulation, her heart rate was 115 per minute and blood pressure was 90/60. All peripheral pulses were felt equally and bilaterally. Disability, her GCS was 15/15 and pupils were 2 mm bilaterally equal reactive. Pain score was 5/10 and her GRBS was 125. Exposure, her temperature was 99 degree Fahrenheit and hypothermia was prevented by blanket, but we were taking care of the lesions also. And on exposure, there was diffuse erythema seen in the chest, abdomen and bilateral upper limbs, and some areas there were macular erythematous lesions seen and some bullae, and in the lips there was crusty necrotic lesions were there, which was erythematous, and she also had bilateral conjunctival congestion was also there. So adjuncts, we have inserted 2 large bore IV cannulas, and for pain we have given her injection paracetamol was given. In lesions, skin lesions like this, mild pain and all, we can give paracetamol. Otherwise, if there is a pain score more than 7 and all, we should plan on opioids. So paracetamol was given to her, and we have instructed the staff to care the patient like a neutropenic patient, because there is a high...
Before giving paracetamol, you want to check anything in this patient?
Allergy to...
LFT has to be ruled out because any drug allergy, like Stevens-Johnson syndrome or any other drug allergy, liver may be involved most of the time. So you have to be very careful when we are giving high dose of paracetamol. 1 dose is nothing. Okay.
And at the temperature also, if our ER is in air condition and all, then we should take this patient to a temperature with 30 to 32 degrees Celsius. Otherwise, lower temperature again can cause problems. And strict neutropenic care is advised because...
What problem can be produced by low temperature in this patient?
Infection.
Vasoconstriction. So the skin barrier is the one which protect you from temperature variations. But here the skin barrier is gone. So this patient is highly prone for hypothermia because of the damaged skin. Like burns. It is like burn case.
And VBG was taken. That was basically taken to do the Scotten score. So in that, her pH was 7.45, PCO2 was 32 and bicarbonate was 20.7, lactate was 0.8 and creatinine was 0.7. Slightly on the respiratory alkalosis was there. Ample history, she doesn't have any allergy.
What type of respiratory disorders they can have, like burns, Stevens-Johnson syndrome? What type of disorder they can have?
Because of the pain, anxiety and all, there can be respiratory alkalosis. Otherwise, if there is any restriction of the
they have restrictive airway disease than obstructive airway disease. They have restrictive airway disease.
That can cause respiratory acidosis. So ample history, there was no allergies, there is no known comorbidities, not on any medication, and last meal was 8 hours back. Even patient had a history of fever since fever 1 week back. That was a 2-day fever associated with redness of eye and some photophobia and pain over the eye. And in view of this eye pain, she was taken to an ophthalmologist and started on moxifloxacin. Later, she developed pain over the skin surface, and later on there was some erythematous lesions and it developed into some vesicles, and she also noticed painful crusty lesions over the mouth and the vaginal area.
Hands?
That was not involved.
Palm
was not in. Palms, nails were not involved, and scalp also was not involved.
Normally all drug rashes, palms are generally involved.
And she was taken to outside hospital and referred for further management. There was no myalgia, arthralgia or anything, and she also had poor oral intake. Other positive history was that she had she took a COVID vaccine 1 month back, for which she had some fever, body pain and all, and she took paracetamol and ibuprofen for that. And there is a history of COVID infection 2 weeks back also, for which she took some Ayurvedic medication. So we don't know the precipitating event. It can be because of the NSAID or the recent viral infection. And on
But you have only two differential diagnoses. One is Stevens-Johnson syndrome or a viral infection. Any other conditions can present like this in a young female patient?
like a connective tissue disorder, secondary to pemphigus
Pemphigus, there is a type of pemphigus that bullous lesions can present. Okay, that's an autoimmune type of disorder. So in a young female, if there is no precipitating features, you have to think about pemphigus
bullous
bullous. Okay, so that has to be considered. Okay.
On examination, her eye, there was bilateral conjunctival congestion. So if we are grading that, it is coming as grade 1 congestion was there, and there was some matted eyelashes were there, and some periorbital edema was there, and on otherwise there was erythematous lesions on the chest, upper abdomen and the upper limbs, and there was some vesicles also seen there. And in the mouth there was multiple erosions over the gingiva, buccal mucosa and lips, and there was reddish and necrotic and sloughed areas. And there in the pervaginal and the perineal region examination, there was reddish and erosive lesions over that region. Then in such lesions, we will be looking for the Nikolsky sign. That means we will be exerting a lateral pressure on the normal skin or the erythematous skin. That time there will be that skin will get detached from the epidermis. Desquamation. Dermis and epidermis will get separated. So mostly over the reddish areas that was present. And there is another sign called as bulla spread sign. So if there is a vesicle or a bulla, if we give a lateral pressure on that, that will start moving and that will spread there. So that and other systemic examination were within normal limits. So we went ahead with the blood investigation. So we checked the CBC because conditions like this, if it is we have Stevens-Johnson syndrome and toxic epidermal necrosis. So in that, if less than 10% of the body part is involved, it is coming as Stevens-Johnson syndrome, and more than 30% it is 10.
So this is 10. This patient has got.
This patient, even though there are multiple lesions, it is altogether it is coming between 10 to 30. So it is like an overlap.
Okay,
overlap of SJS and 10. So we have to decide where to admit this patient. So criteria for admission in an ICU is a presence of hypotension or more than 30% of involvement of the skin, and we will be scoring a Scott score will be done, and if the score is more than 2, we will be planning on admission to ICU. So for doing Scott score, we have to send certain lab investigations. So first we have to check the CBC because SJS and 10 is associated with bicytopenia, anemia, leukopenia and all. So her total count was 9,600 and hemoglobin was 12 and platelet was 3,59,000. That was coming up normal only. CRP was 50, procal was negative. Then these patients can have electrolyte abnormalities also. Her sodium was 135, potassium was 3.3. and calcium and magnesium, everything else were normal. And other complications we should anticipate is they might have renal failure and also. But this patient, it was normal. Urea was 13 and creat was 0.5. And chest x-ray should be done for a baseline chest x-ray because these patients can go into ARDS and pulmonary complications. Her chest x-ray was within normal limit and LFT also was normal. And we should check pre-op serology also, that especially in elderly, this SJS and all is associated with HIV infection. So we should check the pre-op serology, which was negative for her. And in females, since it is a young female, we will have to check the ARNA profile also. This patient was negative. So in order to plan on where to admit this patient, we did a Scotten score. In Scotten score, there are 6 parameters. If there is any history of any malignancy, we will give a score of 1. Then if there is a heart rate more than 120, we will be giving a score of 1. If the urea is more than 18, and if the bicarbonate is less than 20, and if there is a glucose more than 252, and age more than 40, if any of the 2 are positive, then she should be admitted to the ICU, or involvement of more than 30% or any signs of instability. So this patient, only the Scotten score come only as 1, so she can be admitted to a isolation ward. Like she should get negative isolation, and so she should not get infected by any others. Reverse isolation should be. So she was admitted like that. And our plan of care is strict neutropenic care and temperature management. Avoid AC. Give a temperature between 30 to 32. Adequate nutrition should be there. Glycemic control should be there, and pain control should be there. That was our plan, sir. And antibiotics is usually in
the control the pain in this patient.
Pain control, we can give for mild pain and all, we can give paracetamol. Otherwise, we should give opioids. NSAID is not should not be given, because NSAID itself can trigger a Stevens-Johnson syndrome. That should be avoided, sir. And then we should, along with the management of the patient, we
antibiotics, what you selected?
Antibiotic as such, sir, if it is not classically indicated, but if there is any associated skin infection, there is high risk of staphylococcus and streptococcal infection. In that case, we should give a gram-positive coverage. And
what you can give safely?
Augmentin can be given.
First generation cephalosporin can be.
Sometimes fluoroquinolones and all can precipitate this, so that should be avoided, sir. So, and we should, along with that, we should work up for the causes. So, usually the causes are drugs only. So, it can be either NSAIDs, or it can be because of anti-seizure medications, or some medicines like allopurinol, or any patients, if there is a known history of malignancy or HIV, that can cause SJS, and some drugs like chemo drugs can cause SJS.
Sometimes drug interaction also can produce Stevens-Johnson, like allopurinol with amoxicillin. They can produce severe Stevens-Johnson syndrome. So drug interaction and drugs both can produce Stevens-Johnson like features.
In this patient, we didn't get anything like that. Maybe NSAID induced, or because of the recent viral COVID infections. Okay. And treatment wise, as I told, strict neutropenic care should be given, and avoid covering those skin lesions with gauze and all, because that can get sticked into that. Okay. And adequate hydration should be given, because the skin is exposed, so there is a high chance of losing water. So adequate hydration should be given. And if this patient is not able to take anything orally, we can plan on giving a liquid light diet can be given, and avoid placing a Rayleigh tube, because that can cause mucosal erosion. Mainly the lesions will be in the pharynx and the oral cavity. It will not be involving the esophagus, trachea, intestines and all. So these, the upper airway and the upper part of the GIT will be involved.
Albumin, what happened?
This patient albumin is 3.7, sir.
So it is
normal. Then glycemic control should be given. Should maintain a sugar between 140 and 180. This patient, anyway, she was not diabetic, so it was in the normal range itself. Okay. And next is the protection for the eye, mouth and the vaginal region. These patients can go into complications like eye syncytia formation can be there, exposure keratitis should be there. So adequate lubrication to the eye with refresh eye drops or gentle drops should be given for the eye, and the vulvovaginal region also adequate lubrication should be given to these patients. And then role of steroids still controversial, sir, because there can be associated fungal infection also.
Steroids are not indicated nowadays. If you give, some effect will be there, but afterwards nothing, there will not be any change, and produce more damage to the patient.
If at all you are giving steroids also, maximum for 3 to 5 days only, we should
be first 1 or 2 days it will be beneficial, otherwise it will produce lot of adverse effects.
And steroid can delay the healing of the skin, so that is the problem with the steroid. So if at all planning to give steroids, we have to give methylprednisolone 1 to 2 mg per kg once in a day should be given, sir. and this patient was admitted and these things were going on, and after few days she developed very anxiety and very agitated and all. So they are prone to have this psychiatric manifestation because of this type of lifestyle. So a psychiatric consultation was done and adequate counseling and medications were also started for her. And for oral cavity and all care, we started on oral chlorhexidine mouthwash, and these things also were started for her.
Anything else, sir?
Okay, good.
Okay, thank you.